What's up, everybody? Dr. Rossi, shrinksandSneakers.com. So, I thought in the last video I was going to be able to cover everything I wanted to cover about the psychiatric interview, note taking, dot phrases for your EMR, and all the other things that you might want to get set up before you start your intern year of your psychiatric residency. However, what I realized was the video was about 40 minutes long, and I was rambling on and on about all these things, and I love it. I think it's interesting, but I think it's way too long for you guys who are viewing the channel. So in this video, what I'm going to do is I'm going to cover the psychiatric interview portion of it that I was unable to cover in the previous video. So we're going to talk specifically about what's my template, how do I go about starting a psychiatric interview, and what are the key points that you want to hit with every single patient. So let's go ahead and crack right into the video. Starting with the psychiatric interview, and what would be a classic way of sort of laying out a template to describe it and to, again, document the necessary pieces of information. So basically what this was a document that I created. Again, I tailored it to the way I like it. And this helped me to keep my documentation in order, but also it gives us a way of kind of, talking through a psychiatric interview and the order in which I tend to ask the questions and ask the various details of the presentation. So obviously any history starts with a chief complaint, and that's what the patient says they're there to see you for. So patient might give a chief complaint of, feeling depressed over the last week, or they might give a chief complaint of, I took an overdose of Tylenol, etc., etc. So whatever the patient says they're there for is what you're going to write in that spot. Next comes the history of presenting illness, and in the history of presenting illness, you want to gather the details as to what led to the hospitalization, why did they come in, or if you're an outpatient, what led them to coming to your outpatient practice, and what were the details surrounding it, what are the symptoms they're currently having, etc., etc. So starting with the history, I usually like to open with a question like, can you tell me over the last several weeks what has been going on? Right? Something like that. You want to give an open-ended question to the patient. Over the last 2 weeks, what has been happening that brought you to the hospital today? That's a good kind of introduction and way to open the session, because you give the patient free rein to kind of say whatever they want to say at that point. And that's what you're looking for. You're looking for them to say, what the reasoning was behind their current presentation. And the nice thing about that too is you give the person 2 to 3 minutes to do that, right? So you want to give them 2 or 3 minutes at the beginning to just say everything that's on their mind about why they came to the hospital. During that time, it is critical that you, as the psychiatrist, is already thinking about a diagnosis. I would recommend that you try to come up with 3 to 5 diagnoses that you think could possibly be happening for this patient based on the couple of minutes of free association that the patient has at the beginning of the history, right? So you want to start with open-ended questions, and then you want to move more towards closed-ended questions as you start to narrow that diagnosis down. So what you'll start to do is you'll start to hypotheses test your various theories. If you think the person's depressed, you might start asking about neurovegetative symptoms of depression. If you think the person has bipolar disorder, you might be thinking about periods of mania in the past and asking the dig fast mnemonic, right? So you're going to start hypotheses testing, going with more closed-ended questions as that period of gathering information during the history of present illness is conducted. After you have a pretty good idea of what they've shown up to the hospital for, you want to do a psychiatric review of systems. And the reason we do a psychiatric review of systems is we want to make sure we did not miss anything. I would argue in psychiatry, comorbidity is the rule, meaning that people often present with multiple disorders, and meet criteria for multiple diagnoses. So, and also there's overlap in a lot of these things. I'll give a classic example of psychotic depression, right? Somebody could be very depressed, meet all the criteria for major depressive disorder, but they can also have what we call psychotic features, and that would be the classic things like hallucination, auditory or visual hallucinations, delusions, etc. So you can see overlap in terms of the way these presentations occur. So you want to make sure if a person's depressed. Also, another great example is somebody comes in very, very depressed and you fail to screen them for bipolar disorder. You may find out when they start that medication for depression that they suddenly trip into a manic episode. And now if you're in the hospital on an inpatient unit, great, you can catch it and you could say, wow, we avoided a problem. However, as an outpatient doc, you might have missed something critical and this person might go home and decompensate. So you want to be sure you're screening for bipolar anytime you're talking to a patient who's depressed. Suicidal ideation is always assessed for in the psychiatric interview. You want to make sure that you find out whether or not this person has any suicidal thoughts currently, and if they do, how serious are they? What type of planning are they doing? How far have they gotten in the process of the planning? Have they attempted before, right? There's a number of different things you want to do to assess for suicide risk. So that's always going to happen. Anxiety disorders, again, very always comorbid, PTSD, comorbid. You might even throw in here OCD, obsessive compulsive disorder, although I feel like OCD is less likely to present to, say, an inpatient unit or an emergency department unless it's corresponding to something like a suicide attempt because of untreated OCD, something along those lines. So psychiatric review systems to make sure you don't miss anything. Then you want to jump into a past psych history. You want to know what was this person diagnosed with and when, right? You want to know what was their diagnosis, when was it diagnosed, and who was the person that made the diagnosis. Was it a social worker? Was it a psychologist? Was it another psychiatrist? And you want to find out what other diagnoses they may have, right? Because again, comorbidity is the rule. People often have multiple diagnoses. Past hospitalizations, again, that's going to alert you to how severe this person's situation is. Are they have they been hospitalized for depression before? Have they been hospitalized for a suicide attempt before? Have they been so disorganized out on the streets that they needed to come in to be evaluated for psychosis? And so each of those things is important, but hospitalizations give us an indication as to severity. You want to know if they're in outpatient treatment. You will often find many patients are non-compliant or non-adherent with treatment. So especially if they're coming to the ED or inpatient unit, and that's where you want to find out what kind of outpatient experience they've had. So who's their current provider, who's prescribing their medications, what when was the last time they saw that person is another important question. And have they ever been to things like acute partial care programs or other types of outpatient services? So figuring that out is important. Rehab can also be thrown in here, or it can be thrown in with the addiction history. Past medical and surgical history, obviously, sometimes I think psych overlooks medical issues, important medical issues, and doesn't really put as much emphasis as we should on the medical aspects of things. So looking for any type of medical disorders or diseases and anywhere where we could potentially intervene and avoid problems in the future. A great example is type 2 diabetes. A lot of our medications cause weight gain and metabolic side effects, especially the second generation antipsychotics or dopamine blockers. Those medications tend to put weight on people and can lead to type 2 diabetes. So screening for that and treatment for that. Treatment for hypertension is very common in this population. Hyperlipidemia is very common in this population. So being mindful of the medical problems and surgical issues someone might present with. Also, we throw in specifically TBI and seizure because of the neuropsychiatric symptoms associated with both of those. Epilepsy greatly increases your risk of depression, and TBI tends to present usually with irritability and disinhibition. So the person will be more likely to be impulsive. They may also be irritable, angry, aggressive, etc. All depends on where the injury is located. Sexual history is something I usually do in outpatient, and I don't do this with every single patient, but if I suspect that the person has been involved, say bipolar disorder, multiple sexual partners, maybe at risk for HIV or another STD, I will screen and use this and do a sexual history. You definitely want to know about allergies, because if you're going to give medications, you want to know, has this person ever had an allergy to that medication? So specifically medications, but also potentially food and other things. If they're on the inpatient unit, you want to make sure you provide the right diet. The next thing here is the medications, right? We want a detailed list of what their past medication trials were, because that's going to help you to understand whether or not they've ever had a medication that works for them or doesn't work for them. You're going to know what they had side effects on, what they don't like, and what they may have had success with in the past. And then if they're on any current medications, you want to document all of those. And in the documentation, you essentially want to document how long they've been on the medication for, when is the last time they took the medication, what's the what the dose of the medication is, who's prescribing the medication, etc. You really want to dig into the meds. Substance use history, you definitely want to, and I should change that word. This should be substance. Just change it while we're sitting here. I like substance use because I think words matter, and abuse it gives kind of like a negative connotation to it. So substance use history, right? You're probably going to have a UDS and BAL for people who are either in the emergency room or inpatient unit. And then you want to screen for the common drugs, right? Alcohol, cigarettes, or tobacco products, marijuana, cocaine, heroin. But you also want to look at other, right? You also want to see there whether or not the person has been using any synthetic drugs like K2 or Spice, which are synthetic cannabinoids. You also want to ask about benzodiazepines, which people have a tendency to abuse. You might want to think about bath salts, PCP, many other potential synthetic compounds, LSD, psilocybin, etc. You definitely want to get a family history, because family history kind of dictates and tells us or gives us clues as to the genetic components of these disorders. So if a family member has had depression in the past, it's a good thing to explore who that family member is. Is it a first degree relative, or is it an extended member of the family? And what kind of treatment they've had is important too, and whether or not they've responded to medications. Chances are, if mom took sertraline and did well and her depression resolved, then the son or daughter of that mother would have a good response to sertraline too. At least it would be a reasonable way of kind of picking your medication management. Not to say that that's the only way we do it, but that's one of the reasons why the family history is specifically important. You also want to know if there's any suicide attempts or suicide completion in the family. This is important because there is a genetic component to suicide as well. So we want to know, has that been an issue in the family? Finally, drug and alcohol use. Again, I'm going to go back to use and not abuse. Again, I don't like that word. So the social history is the next part here. Where was the person born and raised? And this has a lot, like social issues, psychosocial issues with psychiatric patients is an underrated issue. People tend to try to gloss this over or not address it efficiently. And honestly, we don't have great programs and great initiatives to help people with things like housing issues, but it's a huge problem, and it creates a lot more stress, anxiety, depression for this patient population. So you want to know, where is this person born and raised? Have they ever suffered any type of abuse? And that includes physical, sexual, emotional abuse. You want to know how educated they are and if they're currently employed or unemployed. And if they're unemployed, are they receiving any type of assistance, Social Security, disability, etc. You want to know if they have relationships, because you want to check out to see whether or not this person has been with, has a social support system in place, whether that be a significant other or whether that be brothers or sisters, siblings, or children that they have. Those are things that are very important. I will say that the most protective factor for suicide is having children under the age of 18. So if somebody has children under the age of 18, that is generally considered a very good protective factor for potential suicidal patients. You also want to ask about legal issues, because if the person is hospitalized, they may have a court date pending or something like that. And you want to know whether or not they're facing any kind of legal problems. Military history, because if they have a military history, they might be connected with the VA, or you might be able to connect them with services at the VA if possible. So that's a good thing to know. Obviously, access to firearms can be in the suicide assessment, but also here in social history, access to lethal means increases your risk of suicide in general. So just having access to lethal means alone. And then we have religion. Now, religion can be, again, a protective factor in suicide, but it is only a protective factor if the person's actually practicing the religion, they're attending church, they have a support group at church, etc., etc. That indicates that religion would make a difference. And at the end, you want to do a quick review of systems for any type of medical issues. And that would conclude your basic history taking process. So to wrap this video up, guys, I just want to say that, like, hopefully this is helpful to you to go through, and I think it's a great exercise for you personally as the psychiatric intern to go through by hitting each point and kind of figuring out what way do you want to structure and order your interview process. Now, in the previous video, I've already given you my recommendations as to which books I like, which resources I like for psychiatric interview, but the main thing that's really going to help you is reps. Right? It's like weightlifting, it's like training for the Olympics. You need to get reps in, right? You need to do as many interviews as you can. You need to see as many patients as you can comfortably, right? I don't want you to be stressing, but I also don't want you to be saying like, oh, I'm only going to see like 1 or 2 patients a day and hope that that's going to be sufficient, because it's definitely not going to be. You need to see volume, and you also need to perfect your interviewing style and the way in which you're going to take your notes and do things. One other piece of advice I'll give you is that in the beginning as a psychiatric intern, I used to like to write things down, right? Not, a lot of advanced physicians, like the way I kind of interview now, the way my attendings interviewed, they never wrote a single thing down. However, at the beginning, I think it's really essential you carry that clipboard around with you, and you have like maybe your little template, like a 1-sheet template. I could talk about this actually in the video too. I'll put it in here for you guys, but something to help structure and order, make sure you're hitting all the necessary questions, and again, something to jot down notes about what the patient's saying, because I guarantee in the beginning you're going to be nervous and you're going to forget things that the patient said, or you're going to remember them inaccurately. And I would argue that a lot of the attendings probably, and the people who think they're really advanced with their interviewing, still miss things because they don't write them down and they don't document right away after they see the patient. So that's another good tip actually, is that if you're able to document immediately following your patient encounter, that's the best way, because this stuff is going to be on the tip of your tongue. It's going to be in the forefront of your memory. You're going to know exactly what to do and document. So hopefully this video is helpful for you guys. I'm going to try to cover other topics that I think are helpful for interns, but this is some of the stuff that you're not going to see in books and a lot of people are not going to talk about. So again, like, subscribe to the channel. Every little bit helps us and keeps us motivated to keep making videos for you.